Hello, everybody. Welcome to the research acupuncture and the treatment of post-viral syndromes. So for those of you who don't know, my name is Ian Appleyard. I'm the Research and Policy Manager at the British Acupuncture Council. So we have a presentation today, and let's have a first look at what the objective is. Oh. Why is it stuck? Okay, objective. So what I'm hoping to do is support members in talking about research with patients, with doctors, with whoever you happen to be engaging with, and also to help you promote your clinic online through websites, etc. I think many of you will know that for many years, we had some problems with the ASA, the Advertising Standards Authority, which led many people to feel very restricted in what they could say, which is obviously frustrating if you're trying to attract somebody, patients who are suffering from period pain, and you feel that you're not able to state that you're able to help people with period pain. But when I started at BACC 2021. So one of my first tasks was to work with the Professional Standards Authority to sort of revamp our advertising guidance. So the end result is that we are able, I believe, to say a lot more online with regards to what acupuncture can do. But we have to go about it in a sort of research-minded way. So straightforward, simple statements, acupuncture is good for blah, 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 generally will fall foul of the advertising guidelines because a whole host of reasons, but basically the standard means of analysis of randomized controlled trials is not that favorable for acupuncture. So it's a little bit tricky. There's quite a lot of other reasons to do with the ASA themselves, but it basically means that we can't just say whatever we want, but we can say what the research says. So it might seem a very minor difference, but it's quite important. And I believe it will ultimately benefit not just individual members in building their practice, but also it will benefit the wider acupuncture profession, because we've got a good story to tell. Acupuncture, the evidence is a lot stronger than you might think, listening to some skeptics, and certainly a lot stronger when you think about to date how limited it's used within the NHS. So what I want to do is to support members as far as possible in understanding what goes kind of wrong with the standard way of analyzing things. So what we can't really do, there are a few exceptions, particularly chronic pain, but what we can't really do is state, acupuncture works for this, because the standard analysis, the way and the evidence just is not there. So we have to find ways of talking about the evidence in a sort of, in a way that covers our bases, but I think ultimately will provide a positive story that will actually make patients feel more comfortable with seeing our members to be treated, because they'll feel that there's a kind of sense of this person knows what they're talking about. They're not just trying to state without evidence, without backing it up, that acupuncture does this and does that. So that's the objective. Okay, so in this evening's webinar, I'm going to do a bit of background to start off with. And then I'm going to talk about key issues. These are, background and key issues apply to they apply to any research into acupuncture. So the information that I want to put across are the problems. It's kind of how we should be analyzing and what we should be doing to enable people to see that the evidence that has been produced is actually a lot more positive than you might think, certainly by reading some straightforward statements or listening to some commentators. And I've chosen to look at fibromyalgia in particular because fibromyalgia, there's relatively more research done. So one of the principles of what we need to do today is kind of build an argument for acupuncture, for trying acupuncture, even potentially in cases where the evidence doesn't exist. And that doesn't mean tricking people or anything. It's just that if they understand the context of the evidence and where we're at generally, then they will understand that it's not an unreasonable proposal to say, yes, acupuncture can help you. Okay, so the first thing is the evidence for acupuncture good? Which of course sounds like a very straightforward and simple question, but it does actually have two, perhaps more, but two key meanings. So we'll come on to that in a second. So it's probably worth just highlighting, let's say, some of the negative comments that you might hear from skeptics. Certainly I've heard them more times than I care to count. People will say quite matter-of-factly, there is no evidence that acupuncture works, or acupuncture is a placebo, or thousands of studies have been done and there's no result. So we need to unpick this kind of argument if we're to persuade people that the evidence for acupuncture is better than they think. And in my experience, in sort of social gatherings, people will say, once I say I'm an acupuncturist, they will say, oh, I'm a scientist, and then say one of these three comments. Years ago, before I started in doing research and taking a PhD, I would get quite frustrated because I didn't really know how to respond. I saw sort of the clinical results and felt that this was not right, but I didn't know enough about the research to respond, and it was frustrating at times. Not anymore. In fact, I would say I actually go looking for people like this now, although they're getting fewer and fewer, and that's probably a product of the strength of the acupuncture research that's come out in the last decade and a half. But what I hope is that for many of you out there who do not have the time, perhaps do not have the inclination, which is perfectly reasonable, but are practicing and need to speak to people at times about the research, and so that you're equipped, that hopefully I can give you some kind of handy off the peg answers to certain questions, and these three are sort of off the cuff questions that I think will come up, but would be useful to to how to respond. So what does good mean? That means two things. It can mean, does it mean it shows acupuncture works? So this is probably the first thing that most people think about. If you hear someone say, there is weak evidence that acupuncture is beneficial for long COVID, or there is weak evidence that acupuncture is beneficial for chronic fatigue syndrome or fibromyalgia, it gives the impression, I think, for most people, that probably the acupuncture is not that effective. But that's not really what the sentence means. When they say weak evidence, it means the clinical trial evidence is not very good. So that can mean a host of things. So the clinical evidence that's available is quite small. There are issues with the research, and one of those is the placebo. We'll touch on that more later. So it's like an assessment of the quality of evidence rather than saying that acupuncture doesn't work. So that's an important difference to understand. So here's to give a sense of what the differences are. The evidence map of acupuncture is a document which you can download online. It's free, which is always good. That was done in 2014, and it was done by the American Veterans Association. So they did a whole review of all the things that they think acupuncture could be quite good at. And what I like about this particular review is this diagram that they use, this kind of thing on the left. This is what I mean. So you can see that it's basically got three components. On the y-axis, coming up at the top, it gives a sense of the size of the literature. Because obviously, if no one's done any research, it's very difficult to make any decisions at all. On coming to the right, on the x-axis, they've categorized into four groups. Evidence of no effect, which is really what many people will think when they say there's no evidence that acupuncture works. They will assume that they will assume that somebody did a clinical trial and it came up negative. But you can see out of all of these are just pain conditions, but out of all these conditions, there's only one thing that's kind of sitting in there, carpal tunnel syndrome, and not an awful lot of literature to back it up. But unclear evidence comes here, evidence of potential positive effect and evidence of positive effect. Okay, so coming across some better results. The bubble size is an assessment of the quality of the clinical trials. I mean, the way they actually did it's quite simple. It's not a proper, I would say, it's not a real dive into how good the trials were, but at least they're making clear that this is an issue. So it's kind of nice because it separates out all of these three things, like, is there the literature? Is there any evidence? Was the evidence done well? And was it positive? So we separate a negative result is not, or there's no evidence, doesn't necessarily mean a negative result. So here I've got scientists saying there's no evidence that acupuncture works. Some of you may know of Simon Singh and Edzard Ernst. So this is a fairly old quote in research science terms, but it's a good one. So I think we should use it more and more. So Simon Singh wrote a book, Trick or Treatment, with Edzard Ernst. And he now, I believe, has a kind of a website type thing going on called the Good Thinking Society, which is generally pretty negative about all things complementary medicine. And Edzard Ernst has probably produced more systematic reviews on acupuncture than anyone else. So he's, within the science community very much, professor, all the rest of it. So in their book, they state, 2018, the bad news for acupuncturists, the Cochrane reviews suggest there is no significant evidence to show that acupuncture is an effective treatment for any of the following conditions. Excuse me. So they list quite a number of conditions. And towards the end, they put in glaucoma and vascular dementia. Now, the thing is, I think most people, because the book is targeted at the ordinary Joe public, would take that first sentence to mean that there was an evidence, and they sort of sing the praises about Cochrane reviews as being a kind of idealized, and it is, you know, the bee's knees, as it were, of systematic reviews. So, but the thing is, when you actually look at the review for vascular dementia, no trials met the standard required to be included in a review. So there was absolutely no evidence to say there were no clinical trials. So it's that confusion between saying acupuncture is not effective and saying that there was no clinical trial. Similarly, for glaucoma, only one trial, and that used auricular acupuncture. So there's really no evidence. And the kind of fancy expression for this is absence of evidence is not evidence of absence. So this is the first thing. And when we come to emergent conditions, such as long COVID, this is going to be a big problem because we don't necessarily, well, we don't have access to running clinical trials straight away. Historically, we are dependent on China in some ways to produce the evidence. And there are challenges with the evidence that comes out of China with regards to long COVID, in that long COVID itself became very politicized. So the way of defining whether somebody has COVID or not can be different between different countries. And China often, in their data, define long COVID or COVID is 新冠病毒肺炎. So that 肺炎 refers to lung inflammation. And basically, to be given the label of having COVID, you would need to have a scan, an X-ray, to show that you had inflammation on the lung. So that's unfortunately twisting or potentially twisting quite a lot of the trial data that comes out, and the way the disease spread through different countries is different. So we might find it difficult to rely on Chinese research, as we have done for some other conditions for long COVID. So we don't have the evidence, or we're going to find it difficult to get evidence for some time. So we need to almost find a way to argue the case to actually look at acupuncture for long COVID rather than rely on sort of pre-existing evidence, because it's just absent. So thousands of studies have been done is another thing. Now, it's true. Lots of studies have been done into acupuncture. Lots of studies have been done into the post-viral fatigue conditions. But some of these are mechanism studies. Some of these are qualitative studies. And what we really want in sort of promoting acupuncture, if you like, is the clinical research. And I think many of you will recognize this pyramid. This is the evidence pyramid between from expert opinion to case series to observational studies, RCTs, and those are all mashed together in systematic reviews. So even though we find conditions where some research has been done, quite often not many of the RCTs actually meet the criteria, and very commonly they are small. So in a lot of conditions, we are kind of in a place where we do not have strong evidence in terms of what a card-carrying scientist would assume is strong evidence. So we need to find ways to discuss the evidence and move forward. So the first point was, I've made it actually, but the evidence is just not good. In other words, there are not enough high quality trials. Okay, so the second point is what we need to be able to do is to point out where acupuncture has been researched well, that the evidence is good. So in this case, chronic pain has been researched a lot. And this on the right, this clinical, not trial, this meta-analysis, I will bang on about probably for the rest of my life. The reason is because it is so large and so well done that it's kind of the full stop, that this is the scientific view on what acupuncture can do for people with chronic pain, in particular back pain, OA knee, headache, shoulder pain. So what it says that it works, basically, which is a good answer, obviously, for us. Importantly, it also tells us acupuncture is not a placebo, and the effects are long-term, at least a year. Now, there are actually problems with this systematic review, and I will discuss them a little bit later in terms of for the sham acupuncture and what we know of as verum acupuncture, the real acupuncture, if you like. But in both of those cases, what I will argue is, although that is a problem with this review, it will mean that acupuncture is actually better than the estimate that we've got at the moment. However, how does this relate to things like fibromyalgia and other things? So we need to use this information to try and make the case for acupuncture for other conditions. And one way to do this is to put it in historical context. So when I started, which was actually before 1997, there wasn't an awful lot of research about. I mean, there was some for some conditions like back pain, and here's one from the same Ed Zardes and Adrian White from 1997 for back pain. And the results for this one whoops, what happened there? Okay, the results for this one kind of look like the results for a recent systematic review for fibromyalgia. That they are positive, but they may not really reach the standard of rock solid evidence that we clearly require in order to persuade commissioners, etc., to take acupuncture seriously. However, what we can say to whoever's listening is, for someone who had back pain in 1997, we didn't have this rock solid evidence, but we do now from this Vickers individual patient data meta-analysis. Okay, we do now. And we can look at the difference. So back in 1997, just 9 trials, which are cobbled together, and they're not necessarily good quality trials, with a total of 377 people. So I think, the main thing is quite often with research, there's numbers, the amount of people that you've treated really matters. So you treat, 30 people, 15 people in each group. It's quite hard to get a statistically significant difference. You treat 300, 150 in each group, then you're getting there. Treat 3,000, 1,500 in each group, then you should be getting a result. So in this chronic pain, there are 39 trials and 20,827 patients. Another little characteristic is individual patient data, which basically means it's like one enormous trial. So you can say to patients, you can say to people who are maybe skeptical, well, back in 1997, back pain, the research evidence looks like what fibromyalgia research evidence does today. We were lucky in that the German insurance companies funded these very large trials, which form the backbone of Vickers. And we got this information. And that in some ways is just pure chance, because the British, the NHS, didn't fund it. The Americans didn't fund it. We funded some, but not on anything like the scale that it was done in Germany. So it's kind of a quirk of fate, really. It wasn't that people genuinely looked at this and automatically did the Vickers study. That's not the case. So we don't know what will happen in 10 years' time in terms of fibromyalgia, although I hope to persuade people that there are reasons to be cheerful. Okay, so we do have evidence already for fibromyalgia. And when talking to people and on your websites, etc., it's generally best to sort of point to authority figures. We, in the fact sheets before, we had kind of sort of potted systematic reviews, which is fine, it's very useful. But I think we're in a better position now. Times have changed, and we have more clinical guides, systematic reviews, and other things to rely on. So the strength of this is it's not just an acupuncturist saying, you know, acupuncture works for fibromyalgia or whatever, but it's more what would be perceived as authoritative organizations. So for fibromyalgia, is included in this primary chronic pain. So it's actually in the NICE guidelines, effectively recommending treatment of acupuncture. The European Alliance of Associations for Rheumatology, EULA, also recommend acupuncture in their guidelines. Out of interest, the Turkish Society for Physical Medicine and Rehabilitation also include it. Not in the guideline as such, but they do put it on their website, the American College of Rheumatology. So again, an authoritative body states acupuncture may ease the symptoms of fibromyalgia. So you can use all of that information, put it on your websites. And it's different from simply saying acupuncture works for fibromyalgia, because then you have to potentially prove that to the ASA, who are a bit opaque in what they want in terms of evidence. Please see the guide for advertising on that. But you can put in the ACR state this. Johns Hopkins Medicine, so the medical university, world-ranked university, also puts acupuncture as an effective treatment, or alone or in combination, to treat fibromyalgia. So that's all good. So we're going to think about the key issues. And again, these apply to post-viral conditions, but they also apply pretty much any condition. Post-viral, my personal view is that the real acupuncture is something that really has to be taken into account. And I'll explain why. And what I'm hoping is that we can get the message out collectively through websites, your websites, through the BACSI website, and just keep banging on about it, because we have a risk that research done in long COVID or whatever won't properly take account of these issues regarding Verum acupuncture. Okay, so sham acupuncture. I'm not going to dwell too much on the first bit, because I've spoken before, I think, about this. But I did write an article about sham. Basically, sham superficial needling is not a sham, it's not a placebo. It does have an effect. Off acupuncture point needling also has an effect. So sham is not inert, and we need to reiterate this again and again whenever. But one thing I will talk about today a bit more is effect size, and what should be minimal important difference, but the MID and how that affects us. So don't panic. I'm not going to go full on stats on you. Standardized mean difference, but I do want to just flag it up because it's an important thing. Strictly, what is the standardized mean difference? A difference in mean, so the average outcome between groups. So the average reduction in pain of the acupuncture group minus the average reduction in pain in the sham acupuncture, or minus the average reduction in pain of the medication pharmaceuticals. That's that sum divided by the standard deviation of outcome participants. You'll see this quite a lot. There are quite a few different styles of getting an effect size. For a lot of the relevant research for acupuncture, it's this form standardized mean difference. Two breeds really, Cohen's D and Hedges G. Don't worry too much about it. This is the more up-to-date version, I suppose, one that changes the standard deviation slightly, but don't worry about the stats. So what's the point of SMDs? Basically, when people are pulling together the evidence, the clinical trials for the top of the pyramid, there are quite often different outcome measures. And to enable the statisticians to combine it all, you get these one's done with a ruler, one's done with a scale, modern scale, etc. They use a standardized method. So it's a way of combining, say, results from a WOMAC scale or the Oxford Pain Scale, which don't necessarily match up. They can put them together. So what is small, moderate, and large? 0.2 is typically considered small, 0.5 moderate, and 0.8 large. I'm going to answer the question myself just because it's a bit awkward online. So do you know how these were developed? And it's quite important because often science is presented in a objective and logical way. So these, I think, were developed by Cohen, Cohen as Cohen's D himself, but they are in many ways just arbitrary. It's not decided as a matter. It's not fact. It could be 0.3, it could be 0.1, it could be 0.4. You can change it. It's kind of literally a man-made idea, and that's quite important because it's not pure science in that respect. It's a convention. So why SMD is important is because this is a hurdle, and acupuncture was not included in the osteoarthritis guidelines with NICE, and I've recently published on that, and you can read it online. It's freely available at the moment, and we'll make it available for all members hereafter on our website. So basically, guidelines will set an MID of some figure, and they set it as 0.5, and that becomes a hurdle that acupuncture must jump. So it's 0.5 compared to placebo. So why is this a problem? Because sham acupuncture, as I mentioned earlier, is active, it effectively means that the hurdle is placed higher for acupuncture than it is for medication, because that placebo is a pill and with just sugar in or wheat, and doesn't do anything, whereas the sham acupuncture is active. So even though it kind of looks like the same baseline of comparing to placebo, the acupuncture has been forced to jump higher. And we'll talk about that with fibromyalgia shortly. So paradoxes. So what is the paradox, which is in acupuncture research? So NICE, for example, NICE analysis for primary chronic pain compared to placebos, the SMDs, were as follows for 3 of the pharmaceuticals. Antidepressants minus 0.5. So you may remember that's a moderate or middle ranging thing. Tricyclic antidepressants is minus 0.99 and NSAIDs minus 0.28. So that's bordering on a small effect size. Acupuncture has done this systematic review, showed for acupuncture versus placebo, the SMD is minus 0.42. Remember, the whole point about the standardized mean difference is it's meant to be sort of kind of generalizable and you can put things together. So we would naturally think that tricyclic antidepressants are going to be the better option for people because that has a bigger effect than acupuncture. However, in the review, acupuncture, this is fibromyalgia, acupuncture was superior to amitriptyline, which is the tricyclic antidepressant, by a mean difference of minus 1.81. So that's basically a visual analog scale of 10 being as bad as it could be, 0 being absolutely no pain. So the average change in the acupuncture group was 1.8 centimeters better than the average change in the amitriptyline. So that's a kind of, we have this problem, it's almost illogical because the research, 2 different research don't seem to match. So Verum acupuncture, and again, just reiterate, I think this is, when looking at post-viral conditions, this is super, super, super important. I think we get lucky with the things like osteoarthritis of the knee because fixed point protocols are sort of similar to what we might do in practice. There's not such a big change. But the Verum acupuncture needs to be looked at. So Verum again means real. So we've got the idea of points, prescriptions, and number of treatments. So point prescription. Why is this a problem in a clinical trial for things like fibromyalgia? And it will apply for long COVID as well. So pain is obviously the main symptom. First of all, it's all over pain. So it doesn't, the points prescription, if you have a standardized, which means everybody in the research group, in the acupuncture group gets exactly the same acupuncture points no matter what. Semi-flexible means there's like a little bucket of points and people can choose, and individualized. So from our theory and what we would believe as traditional acupuncturists, as you move from standardized to individualized, acupuncture should become more effective. And we can see with such a complicated condition as fibromyalgia, and again, for pretty much any post-viral condition, it's going to be very tricky because some people may also have severe headaches. Some people may have insomnia, anxiety, tiredness, IBS, muscle stiffness. So all of these are quite big issues that we would deal with or try to deal with through adapting the points prescription. And none of that adaptation gets done in a standardized protocol, and perhaps not that much in a semi-flexible. The other thing would be is, I think we know that with fibromyalgia, and as it seems with long COVID, things fluctuate. So it means that we as traditional practitioners would be potentially changing our diagnosis or addressing different things depending on what was presenting on the day. So all of that gets sort of ripped out of a clinical trial which doesn't, which uses a standardized protocol. And obviously acupuncture may be less effective. Number of treatments and frequency of treatments. This is another big issue. So, and again, it's something that we can kind of use the evidence that's been produced for chronic pain. Because it's stronger, we've got a lot more, as I say, 20,000 or so individuals within the overall analysis. And in this particular thing, I think it's about 4,000 individuals, which is a lot. But basically, it shows that acupuncture has a dose response, which in layperson's terms just means if you treat someone more, they will get a greater reduction in their pain, which I think we all understand from clinical practice. If you treat someone 3 times, they may have some benefit for their back pain. But if you treat them 10 times, you'll be much more confident that you'll have a better long-term result. And there is a good article here, which I recommend, which talks about dose dependence and how it's important, because it's a very important issue that we need to get the message out there, basically, to say the acupuncture is not really reflecting practice as well as it might. So, similarly, acupuncture for depression, a systematic review, a good study. So there's more evidence again for depression than there is for fibromyalgia. So what we can argue, because although chronic pain and depression are obviously different conditions, we see the same thing, is that acupuncture is more effective depending on the dose. Now, there's a common sort of statement from in research articles, even in NICE guidelines. Basically, they say acupuncture in China gets a better result because Chinese people are believers. So it's effectively ascribing the benefit to being a placebo, and that because the Chinese people have it within their culture, they feel that it's kind of a psychological benefit. But it's also the case, and this review looked at it, that the number of treatments show a clear improvement. So it might not be that Chinese people feel acupuncture is great. It might be simply that they get so much more treatment in their clinical trials. And the studies include 30 to 40 treatments, 3 to 5 times a week, where even in the best Western trial, you'd normally get 10 or 12. So there's a big difference, and that may well account for why Chinese trials get better results. There are potentially other reasons, but that's a key one. So what's the problem with the standard analysis? First of all, we've got this sham problem, that the sham is active, whereas it's not necessarily active for the pills. So it's a different comparison. But not only that, we have this additional weight that acupuncture is not actually being delivered in the way that you will be delivering it in your clinic, and may not even be delivering it in a way you would like to deliver it if people can't afford or have no time to come twice a week. So all of these things are sort of drawing, minimizing the potential benefit of acupuncture, I suppose. So when we look at a systematic review, kind of have to have in the back of our minds, these are going on. And when you talk to patients about it, let them know. So let's have a look at fibromyalgia evidence. Morty. So most recent systematic review, or a recent one. So on the plus side, so it gets a thumbs up, the reviewers state, and again, just for you, if you're putting something on your website and you want to put something in like this, it's okay to put in this quote as long as you reference it. that's okay. You'd probably fall foul of ASA guidelines if you just simply say acupuncture is good for fibromyalgia. So it's a minor change, but it just allows the patient, allows the public to know where you're getting the evidence from, and then they can make their decision. And probably for many people with fibromyalgia, they read this. Moderate quality evidence supports acupuncture in reducing pain in patients with fibromyalgia. Therefore, acupuncture is recommended. So moderate quality, remember that's a comment on how good the clinical trials were, not on the size of the effect. As it happens, the measured effect is moderate. But again, remember, these are being compared to placebo. So if the placebo wasn't active and the acupuncture was as you deliver in clinic, this might be a bigger SMD than minus 4.2. Okay, so the two things that they noticed got a significant difference was alleviation of pain and improved well-being. Another fairly recent systematic review using very similar clinical trials, but different researchers, obviously. This one from Korea. Their conclusion, Verum acupuncture, so the real acupuncture, is more effective than sham acupuncture for pain relief, improving sleep quality and reforming general status. So that's well-being, basically. So we've got one more kind of asset, if you like, sleep quality. All positive. But when does it start to look a bit negative? So back to that first review, they also say no evidence that acupuncture works on fatigue, sleep quality, physical function, or stiffness was found. So that might make people feel, your patients, etc., if they're worried about sleep quality in particular, that it's not for them. Similarly, the other one said no evidence was found, or evidence that it reduces fatigue was not found. So again, sounds quite negative. So what we have to do is look. So within a systematic review, not all clinical trials measure the same things. You've got different outcome measures. So in this review, the 2022 one, pretty much all clinical trials for fibromyalgia measured pain, which you might expect. But the others, it was only 4 studies, 2 studies, 3, 2, and 4. And you can also see that the number of people within the study reduced. So you go from 715 here to 104 for stiffness. So it's a lot harder to get a statistically significant result if you don't have many people. So what we can also notice in the 2 things that this review found positive result for just happened to be the 2 things for which there were more than 300 patients in their analysis. Everything that's got below 300 patients did not come up as a statistically significant result. So what's going on? It could be the absence of evidence we spoke about at the beginning, or simply not enough clinical trials. So if you had 12 clinical trials looking at sleep, you might get a positive result. It might be the standardized treatments reducing effectiveness. They did actually test for this, but they found that they didn't really have enough data to make any conclusion. So that hasn't been tested. And there's quite a few things that would also need to be considered, but we'll skip over that. The active nature of the sham placebo procedure. So if sham acupuncture is active, so it's effectively reducing the effect size, reducing the SMD, because it does work, the sham acupuncture. And insufficient number of treatments. They also tested this, but there wasn't enough data again. So, but we can rely again on the depression and the chronic pain to say, well, more treatments make a difference there. So why shouldn't more treatments make a difference for fibromyalgia? It could be a combination of all the above, that all of these things can be true. Or potentially the explanation is acupuncture doesn't work for these outcomes. But if you can present to your patients, to your community group, or whoever you're talking to, your GPs, then they can make the decision. I mean, probably I'm biased, but I think my view is it's all the above. And it's not that acupuncture doesn't work. So, as I say, in the arc of history, once we get the evidence, fibromyalgia will be like chronic pain. We'll have good evidence and it will be of benefit. Just to remind you that you can use systematic reviews on things. And that's it.